Good evening, Jyoti ma'am.
Good evening, sir. Good
Anand
evening.
sir, good evening.
Good evening.
Good evening.
Dr. Lakshmi, welcome.
Yeah, welcome. Good evening.
ये कैसे बंद हो गया?
Please start.
No, sir, you can start.
Good evening, ladies and gentlemen. Welcome to Secrets of Neurology. As we all know, it is a knowledge feast for all neurologists. This probably is one of the longest running web series in India and definitely in the field of neurology. This is episode 19th. As we know that we start at 8 and we conclude by 9:30, maximum by 9:45. We give a very, very warm welcome to our course directors, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan. Thank you for enriching us, enlightening us, and showing us the path, sir. And also a very, very warm welcome to the faculty members of prestigious Ram Manohar Lohia Hospital. An honor and privilege for me to briefly introduce Dr. Sudhir Shah. We all know him extremely well, professor and HOD at prestigious NHL MMC and SVPI MSR, Ahmedabad. Dr. Shah is also Director of Neuroscience at Sterling Hospital, Ahmedabad. Many awards and rewards to sir's credit, but just to mention a few, Padam Shri because of his work to society, science and patients at large, Dr. B.C. Roy Award, and recipient of UNO Award. Our second course director is equally contributive, Dr. Lakshmi Narasimhan. Many awards and affiliations to Dr. Narasimhan's credit as well. Paltussi Advisor, A.V. Baker's Award, Best Paper Award at American Academy of Neurology, Clover Elsevier Atlas Award. Sir, the entire students fraternity is extremely honored to have both of you as program director. May I request both of you to take it forward from here.
Thank you. Thank you, Dr. Manoj, for those kind words and introduction. We are really grateful. At the outset, I must thank all the delegates for their unflinching support all this 1.5 years or more. Now, as has been mentioned, this is 19th consecutive uninterrupted episode. Every month, usually on last Friday, we meet and discuss neurology at a very different level, very mightiest level. And I'm sure students at DM neurology, DNB neurology, the freshers, and even the seniors would learn and enjoy a lot from this series. My heartfelt gratitude to my co-course director, Dr. Lakshmi Ranganath Narasimhan, who is a very profound, well-read scholar and a gentleman, and my personal friend, and his continuous support and efforts have made this possible for me to bring to you. I also must thank today's faculties from RML, Ram Manohar Lohia Hospital, Delhi, particularly led by Dr. K.S. Anand, and I must thank them for accepting our invitation. Not the least, I must thank with full heart the team Globusel INTAS, presided by Mr. Chadda, who has given logistic support as well as a lot of propagation of this idea across India. And I must tell you that there are several other delegates from adjoining as well as distant countries, right from Thailand, Sri Lanka, Bangladesh to Gulf countries. Not only that, but Canada, UK, and USA also. Many friends keep on joining this webinar series, and I must thank them with full heart and gratitude. I would like to introduce today's team. Dr. C. Shruti is the resident in neurology. She will do case presentation. Next slide, please. Dr. Shiv Saini is another resident of neurology at RML Hospital, Delhi, who would take it further and maybe dissect the case a little more. Next slide, please. We have no less a person than Dr. Jyoti Garg, who is a professor, Department of Neurology at ABBIMS and RML Hospital, Delhi. She is a professor in department. She's an MBBS and MD medicine from MGM Medical College Indore. And she is also DM and DNB in neurology from AIMS New Delhi. She has to her credit many publications in national and international journals. She has the credit of initiating and starting thrombolytic therapy in her own hospital, RML, and that was for the free of cost type of therapy for last 4 years. As you can see, her areas of interest are stroke, demyelinating disorders, CNS infection, motor neuron disease, and dementia. Next slide, please. And the boss, the head of department, professor, senior consultant neurologist, and our big good friend, Dr. K.S. Anand, would give the top off and the final remarks. He is the professor and head senior consultant neurologist. He is attached to PGIMR and Ram Manohar Lohia Hospital. He is adjunct faculty to Lady Hardinge Medical College, Delhi, and visiting neurologist, WS Center. He has been attending neurologist to some other hospitals like Guru Harkishan and Gurudwara Bangla Sahib. And he had this former fellowship training in USA from Presbyterian Medical Center and Baylor Medical College of Medicine. And he has 100 paper presentation, various national international journals, and over 100 excellent peer-reviewed publications as journal articles. Written book chapters and has authored also books, and especially as an editor-in-chief of Asian Journal of Cognitive Neurology. As we know that he is very much interested in movement disorders, where he had a fellowship, cognitive neurology, where he is a journal editor-in-chief, headache, neuro rehab, including yoga. That is where I think my frequencies match maximum, all these 4 areas, and of course, use of botulinum toxin. It is a fun to listen to his superb delivery. He gives a very eloquent speech and sometimes witty also. I'm sure you will enjoy his talk. Next slide, please. With these, I would like to hand over the proceedings to Dr. K.S. Anand. And once again, I stand with full gratitude, full heart to all of you who have made this webinar series this much successful, and you have encouraged us to take it forward. And I hope to continue this for the months and maybe year to come. Thank you very much.
Thank you, Dr. Sudhir Shah, for the kind. Now we're going to present an interesting case of neuropathy. The case will be presented in 2 parts. First will be the clinical history, which will be presented by Dr. Shruti, followed by the further discussion, investigation, and the final the diagnosis by Dr. Shiv. So may I ask Dr. Shruti to start her presentation. Yeah.
Yes.
Dr. Shruti, before you start your presentation, with the permission of the chair, Professor Sudhir Shah, sir, Professor K.S. Anand is my hero, sir. In fact, I have been associated with Jyoti ma'am, Dr. K.S. Anand and Bajaj sir and the entire department. And my associations runs for years. And
Yeah.
I'm indeed grateful for you for accepting this, sir. And thank you so much. From the bottom of my heart, I just wanted to thank you. Thank you.
Thank you. Thank you, Doctor. Yeah, Dr. Shruti. Yeah.
Yes. Good evening, everyone. Is my screen visible? Or?
Yes, yes.
Yes, yes.
Visible.
I'm Dr. Sri Shruti, a senior resident from Department of Neurology, Dr. Ram Manohar Lohia Hospital, New Delhi. Today, we are going to discuss about a case which is of a 47-year female who has no formal education, who is a homemaker by occupation and a resident of Bihar, who presented to us with the complaints of impairment of sensation and burning pain in both the lower limbs of 12 months duration, impairment of sensation and burning pain in both the upper limbs a week later, so around 12 months duration, and slippage of slippers from both the feet of 8 months duration and weakness of fine movements of both the hands for 4 months before presenting to us. So discussing about each complaint in detail, initially first complaint was sensory and in both the lower limbs and for the duration of 12 months. Patient started feeling burning sensation and associated with pin prick-like sensation in both the lower limbs, which started in the sole. It was in the anterior half, that is with the toes, and then later on progressed backwards towards the heel too. And patient said that the complaints worsened on wearing chappals or when she placed her feet over the ground. Thus, complaints ascended upwards, like within 7 to 10 days, patient started feeling the similar complaints up to mid-calf level. And it was throughout the mid-calf, like circumferentially. And she also started noticing that she had decreased perception to touch hot and cold temperatures. Within 2 to 3 days, she says a similar complaint started in both the hands too. And it started in the tips of the fingers initially. And within 10 to 12 days, she said that it progressed to hands, both palmar and dorsal aspects of the hands, and later on to the lower half of the forearm. And even in the hands, it was circumferential. She said the similar complaints worsened on attempting to hold objects. And with time, there was also a decreased sensation of touch and temperature to hot and cold in the hands too. At the time of presentation, like 12 months before presentation or the starting of these symptoms, there wasn't any sensation of walking on cotton wool or falls in the dark or wash basin attacks associated with the weak abnormal sensation and burning sensation in the feet. However, she also didn't complain of any decreased sweating, dryness of skin, loss of hair over the affected region. There wasn't any difficulty in negotiating feet into the slippers or any decrease in the hand grip passage, which she noticed initially. And there wasn't any thinning of the limbs or twitching of the muscles that she noted initially. And neither did she complain of imbalance while walking. And with time, there was progression in symptoms, which there was a weakness in bilateral lower limbs in only to the distal aspects of the lower limbs for 8 months duration. And later on, she also noted weakness in both the upper limbs, which was also distally distributed for 4 months, and multiple ulcerations over the hands and feet for 3 months duration. As she claimed that severity increased with time, but the complaints didn't ascend further, and the symptoms restricted to the distal forearm, hands in the upper limb, and the distal calf and foot in the lower limbs. So in the lower limbs, the weakness was initially as a difficulty maneuvering foot into the slippers and intermittent feeling of loosening of grip over the chappal. Slippage of chappals with awareness started later on, a month or 2 later. And there wasn't any complaint of any proximal weakness as such that is complained by the patient. And this was not associated with any low back aches or radicular pains, and no history suggestive of any foot drop or change in the gait as per patient and also the attendants. And there was no thinning of the limbs or twitching of the muscles in the affected regions. in the upper limbs, patients started complaining difficulty in handling and gripping the objects for 4 months. Initially, she said that she would put in more effort to grip an object while using her hands. And with time, she started noticing that there was decreased grip in either of the hands, initially to the weighted objects and then even to the lightweight objects like spoon. And there were many instances wherein that would slip off from her hand. And with time, she also claimed that she had difficulty tearing chapatis, wherein she required the assistance of family members for the same. And there was no history suggestive of any proximal weakness in the upper limbs too. And she never complained of any neck pain or radicular pains associated with these worsening of symptoms. And no thinning of limbs or twitching of the muscles of the affected parts were claimed by the patient. And 2 to 3 months prior to the admission, patient said that she found that the worsening of the loss of touch and temperature, and it was near complete loss. And initially, patient had slippage of chapels with awareness. And with time, she claimed that there was slippage of chapels without awareness. And patient and family also claimed that patient developed multiple wounds over both the feet while walking barefoot on the farms. And she started using shoe for 2 months before the admission. And patient sustained multiple burns over both the hands while preparing food in the kitchen. Because of these sustenance of multiple injuries to the feet and to either of the hands, patient had to limit her daily activities within the home, and family members asked her not to prepare food or work in the kitchen as she is injuring herself. And this happened for the 1 month before her admission into the hospital. There wasn't any history or suggestive of involvement of any of the cranial nerves or long tracts, and there was no history of proximal weakness in any of the limbs or neck or truncal muscles when she presented to us, and there was no history suggestive of any spinal cord involvement like any sensory level, and no history of any altered sensorium, loss of consciousness or seizures or fever that occurred before the onset of the symptoms. And there wasn't any history suggestive of any autonomic dysfunction like postural hypertension, decreased sweating, or abdominal bloating that is given by the patient. And apart from that, there wasn't any history of decreased appetite or significant weight loss that is noted, and no history of any bone pain, fractures on trivial trauma, polyarthralgias, or prolonged fever or rash, or chronic fever and cough, associated cough and hemoptysis, and no history suggestive of any Raynaud's phenomena. There wasn't any history of discoloration of urine on prolonged standing either, and no history of any high-risk behavior, no history of any chronic bowel disturbances, and no history of prolonged drug intake, and no history of occupational exposure to heavy metals. However, exposure to pesticides could not be ruled out because she used to work in the fields wherein the pesticides were used. However, she denies any direct exposure to the pesticides. So coming to the past history, she was a non-diabetic, non-hypertensive female, no history of any endocrinopathies, and no history of Cox infection in the past or history of Hansen's disease, and no long-standing respiratory illness as said by them. And personal history, she was a vegetarian, and appetite was normal, sleep undisturbed, bowel bladder habits were regular, and there wasn't any history of any substance use. Coming to the general physical examination, patient was conscious, well-oriented to time, place, and person, and all the hemodynamic parameters were stable. There wasn't any pallor, cyanosis, icterus, or pedal edema, or generalized lymphadenopathy that is noted. No skeletal deformities or skin pigmentation over knuckles or glossitis or stomatitis or conjunctival congestion that was noted on examination. There weren't any neurocutaneous markers found, and there was no thickening of nerves, peripheral nerves, or hypopigmented or hypoaesthetic patches over the body. However, on examination, it is found that there were multiple old heel scars that are found all over the lower half of the legs, and the skin was dry and scaly over by both the feet. Coming to nervous system examination proper, mini mental status examination, the score was 27/27 as she has no formal education. The other 3 steps which required education couldn't be examined. Cranial nerve examination was normal. Motor system examination, there wasn't any wasting or fasciculation seen. Tone was normal in all the 4 limbs at all joints. And power on examination, weakness was noted in the small muscles of hand and dorsiflexors and plantarflexors of bilateral lower limbs at the ankle. And deep tendon reflexes, apart from the ankle jerk, which was bilaterally absent, all the other deep tendon reflexes was present normally, and plantars were bilaterally flexor. On sensory examination, patient claimed, and it was 70 to 80% loss that is noted to pain, touch, and temperature over both the lower limbs and also upper limbs. In upper limbs, up to the mid forearm level, and in both lower limbs up to the mid calf level, and it was circumferential, not following any dermatomal pattern or any sensory nerve distribution. Joint position sense and vibration were impaired below ankle level, and Romberg sign was positive. Cerebellar examination was within normal, gait was normal, and there wasn't any signs of meningitis, and cranium spine examination was normal. So other system examination was non-contributory. To summarize, it was a 49-year married female with no known medical comorbidities who presented to us with a chronic progressive distal symmetric sensory motor neuropathy involving all the four limbs, like with a history of multiple ulcerations over the involved region without autonomic bowel, bladder, cranial nerve, and long tract involvement. The next part will be continued by my friend, Dr. Shiv.
At this stage, we can have the differential, because we are dealing with a case of chronic distal sensory motor symmetric neuropathy involving all the four limbs. So can we have discussion with the possibilities at this stage?
These are the differential.
Okay.
Shruti, can I share the screen?
Yes,
Can you?
sure.
Yeah. Go to the.
My screen is visible.
Yes.
Yeah, visible. Go ahead.
On the basis of history and the complete examination, we kept a provisional diagnosis as chronic progressive distal symmetric sensory motor polyneuropathy. As we know, the polyneuropathy, the differential is very wide, but in our scenario, we kept the differential, which is the first possibility always in the most common cause was diabetes. So first was diabetes. Other causes include vasculitis, CIDP, nutritional causes, sarcoidosis, infections like HIV. We kept in our patient, and further workup was done to rule out the different causes to reach the diagnosis, and found the etiology of this in this patient, the polyneuropathy. For this, we have done the basic lab investigations, which include hemoglobin level, which is 10.1 gram, showing the moderate anemia. But the peripheral smear was showing normocytic normochromic picture. Apart from that, TLC count was 7,000, platelet count was 2 lakhs, total bilirubin level 0.4, SGOT, SGPT was 20 and 14, alkaline phosphatase 49, blood urea was and creatinine was also normal 31 and 0.8, sodium potassium was also within normal limit 136 and 4.4. Calcium was 8.6, which is on the lower side, with the phosphorus was normal 1.9, and the random blood sugar was also checked, which was 118, and ESR was 41. After the routine basic investigation for the polyneuropathy workup, we have done the nerve conduction study, which shows motor nerve conduction study shows prolonged distal latencies and severely decreased amplitude of CMAPs in a right tibial, peroneal nerve, and decreased conduction velocity in right tibial nerve with normal minimum F wave latencies. upper limb study was done from the right ulnar and medial nerve, which was normal, but the sensory nerve conduction study was non-recordable. So this study shows both axonal and demyelinating pattern, but due to the severely decreased amplitude, we kept acquired axonal more than demyelinating sensory motor polyneuropathy. This is the nerve conduction study. This a median and ulnar nerves study was almost normal. The peroneal, the amplitude was very low with the reduced velocity in right tibial, but there was also minimal increase in the distal latencies was also seen, but the sensory study was non-recordable with F-wave latencies within normal limit in both upper and lower limb. And in the lower limb, the F-wave was not recordable. So on the basis of routine lab investigation, after the lab investigation and the nerve conduction study, further causes for this polyneuropathy was workup was done, in which the C-reactive protein and RA factor level were done, which was negative, and ANA was also negative. HBs antigen, anti-HCV, HIV was also negative. The HbA1c was done, which was 4.6, and TSH level were also normal, 2.1. Although the vitamin B12 level was found to be in the low side, like deficiency was found in 128 picogram per ml, but as we previously slide seen that the anemia was there, but the peripheral smear doesn't show the macrocytosis and the macrocytosis and the other features of vitamin B12 deficiency anemia. ANA profile, complete ANA profile was done, which also included anti-ROLA antibodies and other antibodies, which was also negative. CNCA, PNCA, anti-GBM was also done, which was negative for vasculitis workup. Serum ACE level was also done for sarcoidosis workup, which was also within normal limit, less than 40. A routine investigation like ECG, chest X-ray, and USG abdomen to rule out any bronchogenic carcinoma or mass in the abdomen, and for the malignancy was also found to be, there was no any suggestive of malignancy was found. So on the basis of this, we thought that like in the history also, we didn't found any symptoms of diabetes like polyuria. On investigation, the HbA1c level and the random blood sugar level was also normal. So diabetes was and fundus was also normal. So diabetes was almost ruled out. Thereafter, we thought about the vasculitis, the CNCA, PNCA level, and after the vasculitis, for the Zocran, anti-ROLA antibodies were also negative. Thereafter, we thought of any paraneoplastic, then routine chest X-ray, USG abdomen was negative. Then for sarcoidosis was negative. So we for the workup for neuropathy, as we know, the final diagnosis in the most of the cases, as we know, the for the polyneuropathy workup was very extensive, and despite we have seen in the many cases, like despite very much investigation, very much examination and investigation, the cause of the neuropathy could not be found in many cases. So the nerve biopsy is the one modality which will help in to reach the final diagnosis. Many times, and after the nerve biopsy also, we couldn't find the final diagnosis. So we go ahead with nerve biopsy in that case. On the nerve biopsy, we found that these are the hemotoxin and eosin stain. In this, the right sural nerve biopsy was done, which shows multiple well-defined epithelioid cell granulomas. Multiple well-defined epithelioid cell granulomas with giant cells, which was what in this we can see that these epithelioid cell granulomas and giant cells which are seen in this case. they were totally replacing the all nerve bundles, and there was also lymphocytic inflammatory cell infiltration, which were in the form of CD4 helper CD8 positive cells, which were in almost 80% cases, and CD3 and CD20 positive cells were 20%. So all the nerve bundle tissues were totally replaced by these granulomas and the lymphocytic inflammation. And apart from that, there was also focal small areas of caseous necrosis was also found, with occasional Langerhans giant cells were also seen. But there was, however, no foam cells were found, and on lepra bacilli, on lepra stain and G-Linsel stain for acid fast bacilli was also negative. So on the basis of this epithelioid stain, granulomas and giant cells, we thought about the conditions which are showing the granulomatous inflammation, we thought about sarcoidosis, cutaneous tuberculosis, leprosy, and berylliosis histoplasmosis. But due to some like histoplasma antigen was not routinely done in our setting, and the patient was also not affording these further investigation. But the as been previously seen in the investigation, sarcoidosis was the chest X-ray was not suggestive of sarcoidosis with normal serum ACE levels, and for that reason, after the nerve biopsy, we go ahead with skin smear. After the nerve biopsy, we have also done the slit thickness skin smear, which was also negative. But for the epithelioid cell granules were found in the nerve biopsy, so we go ahead with skin smear, PCR for leprosy, and finally, which was turned out to be positive. So finally, the diagnosis of pure neural leprosy was kept, as there was no skin lesions, and no skin lesion, no hypoaesthetic patches, no hyper thickened nerves was found, and there was no any other system involvement like orchitis, leonine facies for the lepromatous leprosy also was not there. So initially we didn't thought of leprosy in that patient, but after the nerve biopsy, we go ahead with the skin smear PCR and the slit thickness skin smear. And after this PCR, we are confirmed the diagnosis, and after that the patient was started on paucibacillary MDT therapy with oral steroids for the pain neuritis, and for the neuropathic pain, she was given capsule pregabalin 75 mg 2 times a day, and for the low vitamin B12 levels, vitamin B12 supplementation was given in the form of 1000 microgram intramuscular injections on various intervals. And after the spated but started on treatment, patient came to follow up only once after around one month after the treatment was started, 1 to 2 months later on. Thereafter, she complains of minimal improvement in the neuropathic pain and the decreased sensations, but the weakness was still there. But after these 2 months, due to the COVID situation, patient was lost to follow up. So after the this COVID situation will be end, then we will I will talk to the patient, and we'll see the improvement in the patient symptoms. So now the discussion. As we know, the distal symmetric polyneuropathy was a very common conditions in India and in worldwide. The most common cause was diabetes, and this was account for the 52 to 33% of the cases in the world. These were the article taken from the JAMA 2015. Other conditions in the metabolic situation include pre-diabetic conditions, also like glucose tolerance with positive, but the HbA1c level was more than 5.5 to 6.5. Apart from that, chronic kidney disease, chronic liver disease, and in the most of the cases, as we already discussed, after the full workup and various investigation, we could not able to find cause of polyneuropathy in 24 to 27% of the cases. Apart from that, toxins, alcohol is very important. Other causes include inherited condition like CMT1-2, familial amyloidosis. Nutritional causes include vitamin B12, E, B6, thiamine, copper deficiencies, gastric bypass surgery, and malabsorption syndromes. Medications like chemotherapy and other medications like phenytoin, nitrofurantoin, metronidazole, hydralazine, isoniazid, and colchicine. Autoimmune conditions can also be present with polyneuropathy, like rheumatoid arthritis, lupus, Sjogren, and sarcoidosis, which could be not included in autoimmune condition. Secondary amyloidosis and other in the infectious causes, HIV and hepatitis B and C, and in the neoplastic causes multiple myeloma and monoclonal gammopathy of unknown significance. Primary amyloidosis is also a cause, and in the neoplastic causes, small cell carcinoma of lung is also an important cause. So, if the patient is present with polyneuropathy, we should be worked up for the different various causes. As we know, as we seen here, there was a very wide list of the causes. So in every case, we could not do workup for each and every case. So the history and clinical examination is also important. But as in our case, like where the characteristic lesion of leprosy, hypoaesthetic patches, hypopigmented patches, and the thicker nerve was not there, despite the after the workup and the nerve biopsy and the PCR, the diagnosis was finally found to be made. So in all these cases, as we know, the pure neural leprosy, which where these skin lesion and nerve thickenings were not there. So in endemic countries like India, leprosy should be a differential in the polyneuropathy cases. Neural leprosy or primary neural leprosy, as we know, there was no classical leprosy skin lesion or passage should be present, but depending on the severity of sensory and the autonomic dysfunction, there could be various degree of hypo or anhidrosis, fissuring, and ulcers along the nerve distribution. And in various studies, it was also found that in the pure neural leprosy cases also, after the treatment or during follow-up, the many patients develop leprosy skin patches or lesion during follow-up after months and even after the years also. The pure neuritic leprosy in the literature is known to be as by the various names like neural leprosy, neuritic leprosy, pure neural, primary neuritic, purely neural, polyneuritic leprosy. In the pattern of nerve involvement in pure neural leprosy, the upper limbs nerves were most commonly involved, of which, as we already know, the ulnar nerve is most common. In the lower limb, lateral popliteal nerve is the most common nerve involved, followed by tibial and the sural nerve. Mononeuritis is the most common presentation of pure neuritic leprosy. However, mononeuritic multiplex is also observed. These are the study by Narasimha Rao. In this, we find that in this study, the pure neuritic leprosy cases from India, it was noted that 26% were mononeuritic, while 39% of the cases, more than one trunk was involved, either on the same limb or the different limbs. So in this study, the mononeuritis was found to be in the lesser number for and the mononeuritis multiplex was found in 39% of the cases. Although the polyneuritic type of pure neuritic leprosy is reported, and in this the polyneuritic type of this leprosy is some workers prefer to call it at mononeuritis multiplex summation, and the symmetric polyneuritis is uncommon in pure neuritic leprosy, and if observed, it calls for the thorough clinical and the bacteriological examination to rule out lepromatous leprosy. As you know, in the lepromatous leprosy, the immunity or T cell immunity was very low in the body. So the lesions of the lesion load, lepromas, which are called as lepromas, lesions, and the leprobacilli load was very much high. So there was a macular lepromatous lesions were found on the diffusely diffusely in the body, and usually symmetrically found over the body, which was usually in a small, very much small size than the tuberculoid, and very numerous than the tuberculoid type of leprosy. And apart from that, these lepromatous macular lesions, there were multiple red-brown nodular infiltrates, which called as lepromas, were also found. And apart from that, on on the face, there could be formation of leonine facies, and madarosis was also there in lepromatous leprosy. Other areas involved were upper respiratory tract, from nasal mucosa to larynx, the eye, lymph nodes, and the testis involvement. So usually, if the, as we seen in the previous article, that if the distal symmetric polyneuropathic pattern was found in the patient which we are suspecting leprosy, so first we thought of for the lepromatous leprosy, but as in our case, there was no other like these macular lepromatous lesions. There was not any lepromas and no feature suggestive of leonine facies, madarosis, and other systemic involvement was not there. The testis, sorry, lymph nodes, eyes, and larynx involvement. So we didn't thought of the leprosy also initially. Um, uh, and now talk about the prevalence of pure neuritic leprosy. According to the Indian studies, pure neuritic leprosy constitute of about 4 to 18% of the leprosy patients, and these are found to be reportedly higher in South India, comprising of up to 18% of the new cases, and it was found to be more common in the men than women. The most common cases were found to be 15 to 13 years of age group. Other clinical features of pure neuritic leprosy include numbness with or without ulcers, or deformity or muscle weakness in an involved limb. On the sensory complaints, the first symptom was found to be in literature is the loss of temperature sensation, followed by, as the disease progressed, the sensation of touch, then pain, and eventually deep pressure are decreased or lost also. Symptoms of nerve pain, sometimes the symptoms of nerve pain can precede the clinical diagnosis by a few months to year. In a small, apart from these sensory loss of pain, touch, temperature, in a case series by S.V. Khadilkar, 19 pure neuritic leprosy cases, 63% of the cases also had proprioceptive loss also. And apart from that, the nerve pain was also associated with pure neuritic leprosy, which was found to be associated, thought to be associated with neuritis. Apart from these, cranial nerve involvement is leprosy was also found, and found to be does not appear to be so rare. The fifth and the seventh nerve, trigeminal and the facial cranial nerves, are the most commonly affected nerves were found. In one study, out of 100 leprosy patients, 22 had cranial nerve involvement. And the facial nerve in the in this study, facial nerve was found to be most commonly involved nerve in 10 patients, followed by olfactory and the trigeminal nerve. Usually on the presentation, affected nerves are found to be significantly thickened in the pure neuritic leprosy cases, and the pattern of the nerve thickening can be nodular or beaded, or in the 5 to 10% of the cases, abscess formation was also found in the affected nerves. For the investigations which were help in finally diagnose pure neuritic leprosy include as it seen by this Indian article. For diagnosis of pure neuritic leprosy, when to suspect is in endemic countries like India, the presence of mononeuritis or mononeuritis multiplex along with tender and large nerve should always raise a suspicion of this diagnosis. Clinical diagnosis on clinical where we can on examination if we can found thickened peripheral nerve trunks, tenderness or sensory impairment associated with, but there was absence of skin lesion and negative skin smear for acid fast bacilli. Laboratory investigation include, as you know, the nerve biopsy, which is gold standard and also gold standard and confirmatory. Apart from this, there was a new investigation like FNAC were also found to be useful. Apart from that, nerve conduction study, electrophysiology is result can be seen. Findings were in the abnormality in nerve conduction studies, but this can be non-specific. And recent days, high resolution ultrasonography and MRI of the thickened nerve is also found to be very helpful in diagnosis these cases. First we talk about the nerve biopsy, and then we talk about the serological test and PCR. We are not going in detail about the FNAC and the MRI and the ultrasound, as these are the recent advances, pure like PCR test and the serological test ELISA, which was found recently more commonly used in diagnosis. And HR, ultra high resolution ultrasonography or MRI is also used, but here we are not discussing in very much detail. For nerve biopsy in pure neuritic leprosy, these were gold standard for confirmation. The most common nerves and sites include superficial sensory radial nerve branch at wrist, ulnar cutaneous nerve near the ulnar border of base of hand, and sural nerve near the ankle. On the nerve biopsy, we can use the hemotoxin and eosin stain, and modified Feist stain is required. On the nerve biopsy, pathologically, we found that changes in the nerve tissue integrity and cellular infiltrate, as well as perineural tissues for fibrosis, epithelioid cell granulomas, acid fast bacilli, and accumulation of fluid and pus can be seen. If these findings were negative or non-specific, additional tissue sample include skin with sensory where the sensory changes was there, and the nasal mucosa, and as we in our case the skin biopsy stains we can use it for as a matter for PCR. We can also use in this. Polymerase chain reaction in this PCR chain reaction is polymerase chain reaction is valuable in diagnosis leprosy in difficult situations, such as in our case like in diagnosis of pure neural cases, in Pauci bacillary cases where the diagnosis of these were diagnosis was not to be made by the normal SSS and other conditions. Like neurobiopsy and other investigations. Patients with atypical clinical presentations and histopathologically features compatible with leprosy. In the PCR, the quantitative and the conventional though two types of PCR was done, in which the quantitative PCR assay amplifying the different Mycobacterium leprae gene targets then include SOD-A16S ribosomal, RLEP, and AG1885B. In the various studies were done for the accuracy of these tests, in which the sensitivity of quantitative PCR was found. These were the systemic review in which the 5 studies were found, in which the sensitivity of quantitative PCR was 78.5%. and specificity was 89.3%, and the sensitivity of the conventional PCR was which are 17 studies was 75.3, and the with specificity of 94.5%. So the conventional PCR was more specific than the quantitative PCR. In the other new investigations for diagnosis of pure neural leprosy or leprosy, serological testing was also done to detection of phenolic glycolipid 1 antibodies, PGL1. It because this is very Bacterium leprae specific. Antibodies, mainly IgM class, are useful for evaluation of infection, and its level show a strong correlation with bacillary load. It was also found to be useful in monitoring the bacillary load also. Detection by enzyme assay like ELISA, passive heme agglutination test, heme agglutination on gelatin particle, MLPA. And it was also found to be useful in follow-up of neuropathy and in monitoring the multibacillary patients treatment as well individuals under relapse risk. As the recent systemic review, it was mentioned 78% average sensitivity of multibacillary patient, 23 of paucibacillary patient, and also apparent healthy context may present positive serology on low levels. So further studies were also needed to see these new methods of diagnosis pure neural leprosy. Finally, management of pure neuritic leprosy. As you know, in the 1982, the WHO classification of leprosy, the divide the multibacillary and the paucibacillary for therapeutic purposes, which was based on skin smear status and number of skin lesions, but there was no guideline from WHO about the classification of pure neural leprosy depending on the number of nerves involved. According to the National Leprosy Eradication Program of India 1987, the pure neural leprosy grouped within paucibacillary leprosy for therapeutic purpose, because as we know that all of them were acid fast bacilli negative on skin smear by definition. Thank you. This was a presentation from me. Now I request Dr. Jyoti ma'am to discuss about the case also. Jyoti ma'am.
Before you do that, may I request Dr. Shruti to show that slide of foot with some lesions, skin lesions there. Can you go back on your slide presentation and show that? I just want to know whether the patient had ulceration. I believe you said in the beginning there were some skin lesions, ulcerations. Is that so? Yeah. So what are these?
Sir, skin lesions was due to some hot metal or hot objects were kept in contact with this foot. So there was ulcer bleb formation which is fluid filled. Thereafter it was healed, and this healed ulcer lesion was found. It was not any patches was not there. In the hand, I didn't have the photo, but there was initial presentation. There was multiple fluid-filled vesicles were present, which were occurred due to because she was used to work in a kitchen where she used to hold the hot vessels with bare hands, but didn't, due to the sensory loss, she didn't able to judge the pressure temperature of the vessel. Thereafter, the multiple fluid-filled vesicles were formed, and at the presentation, it was almost healed.
One more thing is regarding this toes and the arch of the foot. How would you describe? Do you have the photo of both feet together? And what was the angle?
It wasn't high arch. It was because of the angle, like the direction from which the photo was taken. It was that. But however, there weren't any pes cavus or any other skeletal deformities or any changes in the nails or that noted.
Okay, and the toes were all normal, do you think, or there's some abnormality of the toes, or it's okay?
In this picture, it appears as if they are flexed
All right.
Yeah, it
Yeah,
is.
cock up toes, no? They look like
But
that.
it wasn't
And also
like-
there appears to be pescavus.
Yeah.
in this photo, it is appearing as it.
All right.
But
All right. So we have to ignore that. Fine. Thank you. Go ahead. Dr. Jyoti, please.
Good evening, everybody. So, thank you, Dr. Shruti and Dr. Shiv, for giving such an elaborative and differential diagnosis of case. So, we all know, leprosy is an important cause of neuropathy in Indian subcontinent. Especially, they present with mononeuritis multiplex. But if a patient is presenting with distal sensory neuropathy, leprosy should not be ignored as a cause of neuropathy. Especially if you see, in this case, if you see, there were a history of burns and injuries. So if you have a history of burns and injuries in case of distal symmetrical neuropathy, leprosy should be thought of, because as we know, temperature is involved early in the cases of leprosy. So it should be always kept in differential diagnosis of neuropathy, even if it is a distal symmetrical neuropathy. And if you think of these cases of pure neuropathy, this is an important, it is kept as a distinct subgroup of leprosy as described by Indian Association of Leprologists, though there are global cases reported from all over the globe. So, but Indian cases, they constitute about more than 50% of the global cases in case of pure neurotic leprosy. And so it is an important cause of neuropathy we should think of. And there is loss of temperature, which is important to be seen. And generally, there is no skin lesions seen in these cases. But if you follow up these cases, more than 20%, they may develop skin involvement in these cases if you follow them. And slit smear, as you see, is mostly negative in these cases. So if slit smear is negative and you are strongly suspecting a lepromatous neuropathy, a PNL, you should not limit your investigation to slit smear only, or you can make a diagnosis that it is not leprosy. You should further proceed. Now there are newer investigations which are available. Sometimes even nerve biopsy may be negative. So if you go for nowadays we can go for high resolution ultrasonography. It is also important diagnostic tool nowadays for diagnosing for going for the nerve imaging. It may show nerve thickening. It may show assess morphological alteration in nerves, ecotexture, vascularity is different in cases of leprosy. And again, PCR, if you go, it is an important part of investigation nowadays, because even with a very few number of bacilli, the PCR can diagnose, can be positive to detect very few number of bacilli. So it is a high sensitivity and specificity for diagnosing leprosy cases, especially the pure neurotic cases where the slit smear and all other tests are now biopsy is negative. So it should be always be kept in mind. So a diagnosis should not be limited to the skin lesions and slit smear and now biopsy. So this case gives you an important this thing that we should, if you strongly suspect something, you should go ahead for whatever investigations are available. We should go for them. Especially PCR is nowadays coming in a big wave in these cases. And treatment part, already they have elaborated the differential diagnosis and treatment part and other investigations.
Now I request Dr. Anand sir for concluding remarks.
It was a eye-opener for us. Actually, this is the second case which I have seen of subacute to chronic progressive symmetrical sensory motor polyneuropathy. And for the postgraduates, I would just like to tell, whenever we approach a case of polyneuropathy, now there is a thing called pattern recognition. So there are three distinct patterns of peripheral neuropathy. One is a mixed sensory motor pattern. The second one is a pure motor pattern. The third, pure sensory pattern. And in mixed sensory motor pattern, further divided into whether it's a proximal asymmetric or proximal distal asymmetric or proximal distal symmetric neuropathy. So if you have, in this case, we have predominantly symmetrical distal chronic neuropathy. The common differentials comes to mind is diabetes, this is a length-dependent polyneuropathy, then amyloid, and vitamin B12 and paraproteinemia. These are the common ones. But whatever we see the literature of chronic neuropathy, there is no mention of Hansen's. So that was the point we want to highlight by presenting the case, that even if the symmetric polyneuropathy distal type forms about 6 to 8% of all neuropathies, that is mononeuritic multiplex or simplex in leprosy, this should also be considered in the differential diagnosis. Thank you very much.
So, thank you, sir. Thank you, sir. Thanks for a very excellent case. And in our country, whatever be the differentials in any peripheral neuropathy, whether it is symmetrical or asymmetrical or distal, the diagnosis of Hansen's should be one of the differentials, sir. This we have, because it's a great masquerader, and the Western world does not know much about this. Only I think we have to, as you have rightly said, this is a eye opener for all of us, where it is presenting as a typical symmetric distal neuropathy. One of the excellent cases. And secondly, as Jyoti madam rightly said, that when you suspect something strongly, you go all out to investigate as much as you can to establish the diagnosis. So, and for the DM postgraduates, if you should understand that you are not pardoned if you don't know about leprosy in our setup. In DM, you are expected to know anything and everything about leprosy, and all the DNA probes or MRI, whatever diagnostic probes, PCR, both DNA PCR, RNA PCR, and now that there is one more organism which produces leprosy has come, this Mycobacterium lepromatis. So for Hansen's, apart from the Mycobacterium leprae, the Mycobacterium lepromatis is the next organism, which is again phenotypically different. You should know about that. And also the, have you done an X-ray, Saini? Saini, have you done an X-ray of the foot? X-ray of the foot, was it done?
Has not been done, but bone involvement is known.
Well known, but one important thing is it produces what is called a sucked candy appearance, where there is a sucked candy appearance, which is very typical, which is the bone resorption is typically like a sucked candy, sucked candy appearance. So that will also give you a clue. A local, just an X-ray, any distal, that also gives you a clue that the resorption is conical and like appears like a sucked candy. So these are the few points which are examination takeaway points for the postgraduate. Sir, my hearty thanks to you for a wonderful case, sir, and for both madam and you, and I'm very happy, sir. Thank you so much. Thank you.
Thank you very much. Thank you very much.
Yeah.
And sir, Sudhir Shah, sir, you have any comments, sir?
Oh, I am really amazed and so pleased to have seen this type of presentation. Conversely, if we speak from the other angle, so many cases of symmetrical peripheral neuropathies we have been seeing where the diagnosis is lacking, and we just for the sake of our past teaching and experience, we don't think of Hansen or we don't investigate in this much detail. But as you rightly said, we should keep our eye open, and particularly in Indian continent, Hansen leprosy can be a great masquerader, and we should go all out, not only to look from the clinical red flag signs, but also do all investigation. In cases even where the biopsy does not give proper answer, this modalities like PCR and ultrasound and other technologies should be resorted to. I think whenever in a symmetrical neuropathy you are not finding the cause and you are still suspecting some infective inflammatory type of subacute chronic presentation, I think leprosy should be very much seriously considered. That is the message. I'm very thankful to
Sir, before that, Professor Muralidharan Nair, one of the country's leading expert in peripheral nerves, is there on the chat, and he has asked some. Sir, welcome, sir. Professor Muralidharan Nair, sir. Can can I ask the sir to toss any comments, sir, please? This is Professor Muralidharan Nair from Sri Chitra, sir. Sir, can you join us, sir? I saw you in the. Sir has asked a question in the chat. Sir, what was the value of motor nerve conduction and distal latency, and how do you account for the neuroleprosy in the absence of the question is, you can, I'll read the question that's from the chat box.
Yeah.
The question is, yes, what was the value
Meanwhile,
of
yeah.
sir? How do you account to neural leprosy without AFB? That's what he has asked, sir. And now the answer is PCR is positive, so that's even more sensitive than even though the bacilli finding the bacilli. The Phyte Farraco stain was used. What was the stain used, sir?
Lepra stain, Phyte stain, yes, sir.
Phyte, sir. Fine.
So because
So-
the narrow conduction studies values could not conclude that it is due to diabetes or it is due to leprosy or any other reason. So the
Okay,
nerve
fine.
conduction studies are usually of like they have concluded that there was nerve involvement is there, but I only say that it is axonal or demyelinating, but not pinpoint the diagnosis like it was
Yeah,
due to this
same.
leprosy or
Anyway,
acquired with nerve biopsy.
the participation of doyens like
Regarding this proprioceptive involvement,
Commonly, we see axonal type of perinephral neuropathy
Yes, sir.
in Hansen.
Yes, sir.
Demyelinating were also documented in many studies also, but
I just wanted to ask one question regarding this proprioceptive findings as mentioned by Dr. Khadilkar in his report. I mean, what is the experience of other centers? Dr. Lakshmi, did you see how many numbers of patients, how many percentage of patients had proprioceptive involvement in Hansen disease, Hansen neuropathy?
So the large fiber involvement is pretty rare, sir, but not very uncommon, because ours, Tamil Nadu, you know, the
Okay.
Chengalpattu, the areas near in and around Chennai are all hyper endemic for
Right.
Hansen. So we see quite a lot of cases, but even though now that it's slightly coming down, but large fiber involvement is also reported, sir.
Yeah. I think we have also seen, but I think it must be lesser in number than Maharashtra or other, because Maharashtra is an endemic area in as far as Hansen is concerned.
In male patients, the testicular sensations, testing for testicular sensations is also a must.
But coming back to this particular case, when I go back and see that skin lesions and whatever the cause may be due to burns or scars or whatever, it did give a clue that there is something happening to, probably that was one of the indicators that this could be Hansen.
Definitely, what this is my experience also. If you see burns, especially in cases of any neuropathy, you should always look for Hansen's.
Yes, ma'am. I agree with you. Yeah. That is why I asked to show that slide again, because I was quite intrigued to see those lesions.
Sir, my teacher used to say the burns in the fingers is leprosy and syringomalia, and burns in the leg is invariably leprosy. But the teaching goes.
Correct.
In duration, we had another male patient who was 19-year-old, like he was young male, who was working in a factory, who presented with multiple burns and neuropathic pattern with numbness and loss of touch and temperature in all the 4 limbs for last more than 2 years duration. And he presented as mononeuritis multiplex to us. And we did all the set of investigations thinking that it would come to be a leprosy only. No biopsy was done, and even leprobacillus PCR was also done, but all that came negative. And
I don't know. Where do you get your PCR done?
This is there's a leprosy mission
PCR for-
hospital
Leprosy Mission Hospital in Delhi.
in Delhi. There's a trustee hospital which are only usually very much specific for leprosy. They are usually made more emphasis on leprosy cases. Leprosy Mission Hospital. It is like trust Christian Trustee Hospital, Mission Hospital.
Many of the cases of mononeuritis simplex, multiplex, we don't find any skin lesion or scare negative. One should have a high index of suspicion and empirically treat them with the ALT.
We tried, but no other leprosy institute or even in the dermatology department, they didn't agree.
I do my clinical practice. Whenever I see, I do get skin referral and all the tests done. Even if they are negative, you have a high index of suspicion. Thickened nerve, you have wrist drop, or you have wasting in the hand. You should give empirically ALT. And they do respond.
Thank you, sir. Thank you, sir. Thank you. If there is any,
Great. Yeah.
no, sir.
It was a great lesson, very nice deliberation, and we must compliment both students also for elaborating the case in a very great detail.
Sir, the next week we move on to south. From north, we move on to south to Chengalpat Medical College on the February 25th. Chengalpat is, in fact, Chengalpat is a place which is hyper endemic for Hanson's, and they have a very big leprosy institute in Chengalpat. It's about 100 kilometers from Chennai, about 60 kilometers from Chennai, but hopefully they don't choose a leprosy case. And anyhow, thank you so much, sir. We move on to my hearty thanks to Saini, Shruti, Madam, and yourself, sir. Jyoti, Madam, and Professor K. All of them are.
Shah, thank you, Lakshmi. And thank you, Mr. Chadha also from Ventas. Thank you.
Thank you, sir. Thank you. And today we are at the end of 19th session of Secret of Neurology web series, which is the longest ever web series till date. And I, Arun Chadha, Associate Vice President, on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in these last 19 months. And I would like to thank our honorable course director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And I would like to thank our young neurologists, Dr. Shruti Reddy and Dr. Shiv Saini, for presenting the excellent and unique case. Further to this, I would like to thank Dr. Jyoti ma'am for presenting the case investigation and discussion. And thanks to Dr. K.S. Anand, the HOD Ramanohar Lohia Hospital, New Delhi, for providing important learning points and proceeding of the unique case. Once again, thank you for your gracious presence, and it's been a pleasure being with all of you. Thank you for your patience, and I wish you all a very good night now in this month, and we will meet again next month on 25th February 22 with yet another most awaited next session of Secret of Neurology. Till then, stay safe and stay healthy. Thank you.
Thank you.
Thank you, sir.
Thank you,
very
sir.
much.
Thank you, ma'am.
Yes, sir. Thank you.
Thank you.
Bye.
Thank you.
Dr. Lakshmi, Mr. Chadha, and Dr. Heli, will stay back. I have something to discuss. Thank you all.
Okay.
Bye-bye. Thank you. Thank you.
Is Dr. Lakshmi around?
Sir, Lakshmi sir has left.
No problem.
Wait, can we stop going live?